Greetings, class. This is Dr. Weaver, and I wanted to go ahead and create another PowerPoint presentation regarding these complex GI issues or health concerns. I did do one already on peptic ulcer disease, a disease process that you will see quite a bit in the acute care setting. And so this is a kind of long presentation because it does consist of several complex GI issues. And so I figure if I can cover maybe a couple here and there, then whatever I do have to cover in class, which I do try to leave the more complex issues to cover in class for the most part. It's not always the rule. So in this particular case, I think, I'll just cover as much as I can, and that way we don't have to rush through information, and because I do want to make sure you get it. All right. All right. So let me go ahead and share my desktop. Just bear with me. All right. All right. So you should be looking at my PowerPoint presentations as it relates to stomach cancer. All right. Right. So let's look at the definition, the prevalence, and also incidence of stomach cancer. Stomach cancer, or we also refer to it as gastric cancer, is adenocarcinoma, adenocarcinoma of the stomach wall. And so take a look at figure 41.15 for an example or an image of this form of cancer. It does account for more than 26,000 new cases, new cancer cases, and almost 11,000 deaths occur annually. Now, the rate of stomach cancer, especially the distal type, has been declining in the United States, but cancer in the proximal gastric or stomach and the gastroesophageal junction is increasing. Now, Asian Americans, Pacific Islanders, Hispanics, Blacks have higher rates of stomach cancer than non-Hispanic whites. In the U.S., the incidence is higher in men than women, or compared to women, by a 2-to-1 ratio. Stomach cancer does impact older adults. The average age for people at the time of diagnosis is 68 years old. And one thing I want you to keep in mind about that is your book indicates at the time of diagnosis. Typically with stomach cancer, it is not noticed until it is in the advanced stage. I mean, these patients are probably in the third or fourth stage of cancer by the time it is diagnosed. They may have these vague kind of symptoms that, you kind of throw off these vague symptoms. Maybe something I ate that was bad or something, But yeah, so by the time these folks are diagnosed, it's pretty late. Now, more than 50% of these patients are going to have advanced metastatic disease. And they have a 5-year survival rate of all people with stomach cancer, and this is about at 31%. all right, which is not a lot, but again, this cancer is typically caught in the latter stage, unfortunately. Right. Now let's look at the cause or the etiology, as well as the pathophysiologic process. So while many factors are implicated in the development of stomach cancer, there has really been no single causative agent that has been identified. Now, stomach cancer probably begins with a nonspecific mucosal injury because of an infection such as H. pylori. That's something you guys have probably heard about. Also, an autoimmune related inflammation. Sometimes they at least think that it might be due to repeated exposure to irritants such as bile. We know that bile is produced by the liver and stored in the gallbladder, but has to transition into the small intestine uh, um, in order to emulsify fat, if you will. Also, certain drugs, such as NSAIDs, as well as tobacco use. And of course, as I just mentioned to you guys about some of the potential causes of this condition, keep in mind health promotion and maintenance as we continue with this discussion. And of course, we want to talk to our patients about uh, uh, taking over the counter NSAIDs as well as smoking cessation. All right. Now, stomach cancer has been associated with a diet that is high in smoked foods, salted fish and meat, and also pickled vegetables. Um, whole grains, fresh fruits and vegetables are associated with a lower rate of stomach cancer, and of course, this would be a part of our health promotion and maintenance, encouraging these patients to consume this particular diet. Now, infection with H. pylori, especially when it occurs at an early age, is also a risk factor for um, a stomach cancer. It is possible that H. pylori and the resulting cell changes can induce a sequence of transition from dysplasia, meaning abnormal tissue, in this case of the stomach, to full development of cancer. So, in other words, the tissue it does change as a result of the infection, H. pylori in particular. Right. Now, other predisposing factors to consider include atrophic gastritis. There's also pernicious anemia, uh, adenomatous polyps, hyperplastic polyps, and also achlorhydria, which means that latter term means absent or low production of gastric hydrochloric acid. And if you can think about this particular or the latter potential predisposing factor, when someone has a lower or absent pH, particularly lower pH, think about some of the medications that we may prescribe or that might be prescribed for these patients that may neutralize the acid, such as antacids, Malox, and even some of the other drugs such as PPIs and Zantac and what have you. It does reduce the gastric acid, and of course, this could possibly lead to stomach cancer. Now, smoking and also obesity both increase the risk for stomach cancer as well. So again, we're back to health promotion and maintenance. Um, Now, stomach cancer spreads by direct extension and typically infiltrates rapidly to those surrounding tissue and the liver. It is because these other organs are so close in proximity to the stomach, and so it is easier for the cancer to spread to the adjacent organs. Right. Now let's look at some of the clinical manifestations of stomach cancer. Stomach cancer, as I mentioned, often spread to those adjacent organs before any distressing symptoms occur. So by the time these patients um, uh, begin to develop any of the symptoms that may prompt them to seek health care. Um, by the time they get the diagnostic tests, of course, it may already reveal that the cancer has spread significantly, especially to the liver. That's kind of one of the main organs that might be impacted. These patients may experience unexplained weight loss. They may have indigestion, abdominal discomfort or pain, and also signs and symptoms of anemia. And they also may report early satiety, or they may become full a whole lot sooner. All right. Now, anemia is common. It is caused by more chronic blood loss as the lesion, the cancerous lesion, erodes through the mucosa of the stomach, or from pernicious anemia. And This is caused by a loss of the intrinsic factor. As you all should continue to know, is that pernicious anemia results when the intrinsic factor is no longer there. When the cancer eats into the mucosa, remember it is the parietal cells of the stomach that underlies the mucosa that actually produces the intrinsic factor. But if the cancer erodes through different layers of the stomach, then it cannot secrete or produce the intrinsic factor, and therefore these patients, they become anemic and more of the pernicious anemic type. Now, these patients appear pale and weak. These are signs of anemia. And of course, when you are anemic, these patients may report feeling fatigue. There may be weakness, dizziness, and in extreme cases, they may experience shortness of breath. Now, the stool may be positive for occult blood. Remember, we do the fecal occult blood tests on these patients. And if you don't know how to perform that test, which you should, just refer to your fundamentals textbook. This is something you will also be doing quite often. Now, the supraclavicular lymph nodes that are hard and enlarged suggest metastasis via the thoracic duct. So you have these lymph nodes that are above the clavicle. So when it says supraclavicular, it's above, right? So those are the lymph nodes that, when palpated, they will be hard and enlarged. And it will pretty much tell us that metastatic cancer has spread again through that thoracic duct. Actually, I should have been moving um, my slide over here, so my apologies. I'm focused on one thing and forgot about the other, but this is the other PowerPoint presentation or slide that you need to look at. And actually, this is where I last left off at before going to the next slide. Um, all right. All right. Let's see. All right. Now, on this particular slide, let me pay attention to this more. What I want you to do is read the section on diagnostic studies for the rationale for the various tests. That section really outlines for you what these different tests are done, why they're done. The diagnostic studies for stomach cancer are outlined in Table 41.17. You will see where it talks about the upper GI endoscopy, which is the best diagnostic tool because, you are accessing, you will um, place the scope in the patient's oral cavity, of course, down the esophagus, and then it gives you direct visualization of the stomach. And at that point, biopsies can be done, those tissues are analyzed, and of course, um, biopsies provide a more definitive diagnosis of this disease. Um, During this procedure, the stomach can be distended with air, and so this will allow that stretching of the mucosal folds so that you can visualize everything and don't miss anything. Because you don't want to, you want to be able to extend those folds so that just in case that lesion, the cancerous lesion, is hiding in the mucosal folds. And again, this is where the tissue biopsies, the histologic examinations are important in diagnosing stomach cancer. And again, it is more definitive. Whenever you do a biopsy of any a tissue, it is what is more definitive in terms of diagnosing, in this case, cancer. All right, moving along. All right, so let's look at some of the interprofessional management. So the treatment of choice for cancer is essentially surgical removal of the tumor, right? Pre-op management focuses on correcting nutritional deficits and also treating anemia. So before these patients do undergo this surgery and during the pre-op period or before the surgical period, we want to make sure that we more or less tune them up. We want to get them a little more healthier before undergoing such a procedure. And so, the nutrition can come in just about any form, and more than likely might be a TPN. But again, you want to correct those nutritional deficits. Blood transfusions may be in order to correct the anemia. And of course, this helps these patients get through the surgery better. Their outcomes are better when we tune them up and ensure that they are healthy enough, uh, or as much as possible, I guess I should say, because you don't know how advanced this will be by the time it is, the patient seeks help. Now, if the gastric outlet, or if there is a gastric outlet obstruction, then a gastric decompression is going to be needed, and so they might end up putting an NG tube in just to decompress the stomach, because the stomach will be increased in size with a lot of gas that cannot go anywhere. And so at that point, an NG tube might be warranted. Now, as far as the surgical procedure, the surgery is aimed to remove as much of the stomach as required in order to remove the tumor and a margin of a normal tissue as well, just to make sure that most of it is gotten. Right. Now, lesions in the antrum or the pyloric region are generally treated by a procedure called a Billroth 1 or 2 procedure. And so take a look at figure 41.16 for an example of that. When the lesion is, and this is just different parts of the stomach, and that requires a different surgical type and approach. When the lesion is in the fundus, a total gastrectomy with esophageal jejunostomy is done, and so pretty much everything is removed. And so take a look at figure 41.17 for that as well. Now, when metastasis has occurred to adjacent organs, such as the spleen, the ovaries, the bowel, the surgical procedure is extended as needed, and so a resection of these adjacent organs might be warranted. If not total removal, I mean, it may not just be a resection; it might be total removal thereof. So like an oophorectomy, so as far as the ovaries are concerned. Um, all right. Now, if the tumor extends into the transverse colon, then a partial colon resection is going to be done. So it just depends on which body parts are impacted by the cancer, and it may have to be removed. Right. Now, as with any cancer, in most cases, these patients are going to receive chemotherapy and radiation. A number of chemotherapy drugs can be used to treat stomach cancer, which is kind of a good thing in that if the patient doesn't tolerate maybe this one, then maybe try that one, or if not that one, maybe try this one. So having options is always good. Um, Now, combination therapies are preferred as the drugs affect different phases of the cell cycle, the cancer cell cycle. The cancer cell has certain cycles that must be completed in order for the cancer cell to survive um, and wreak havoc on the patient. And so, what the chemotherapeutic drugs actually do is it interrupts some point in those cycles to render the cancer cell ineffective. All right, and so there's some cancer drugs that stop the replication or the proliferation of more cancer cells, which can easily metastasize to other areas. Um, Now, there is also a intraperitoneal administration of chemotherapy agents that can be used to treat metastatic disease. So, if the abdominal cavity is also if the cancer has spread to the abdominal cavity, sometimes physicians will or the oncologist will introduce the chemotherapy drugs into the abdominal cavity to destroy the cancer cells as well. Um, Now, radiation therapy may be used together with chemotherapy to reduce the recurrence or as a palliative measure to decrease the tumor mass and provide temporary relief of, let's say, an obstruction in this case. These cancer cells, they, excuse me, they grow, all right? They grow and they're pressing on nerves and they're pressing on other structures and so forth. And what the radiation does is it shrinks it, and that actually provides relief for the patient, or palliative, as we call it, measures, to help the patient's symptoms, if you will. All right. Now, these are more targeted therapies. Targeted therapies has the advantage of directly going to the cancer, and which has more or less a kind of a local effect, if you will, as opposed to a more of a systemic effect. And this can minimize symptoms or side effects from the drugs. Um, Now, as far as targeted therapy, there's one that is called Herceptin. That one is easier to pronounce. And also the Cyramza are targeted therapies used to treat the stomach cancer. Now, about 20% of patients with stomach cancer have um, too much of the this is kind of a protein, the HER2 on the surface of the cancer cell. And of course, these therapies that I just mentioned above, um, they tend to be able to treat those cancers a whole lot more effectively. All right. Um, Now, the Herceptin targets this HER2 protein. As I said, it's a protein, and it kills the cancer cells itself. And the Cyramza, it binds to the receptor for the VEGF and prevents the VGEF from binding to the receptor. And of course, this will prevent the growth and spread of the cancer. And so you don't have to remember all that. But what I do want you to understand is that these therapies, again, as mentioned, they interrupt that life cycle, and in this case, it can prevent the growth and the spread of the cancer. And so this is just basically how it's more or less um, the mechanism of action of how the chemotherapeutic agent actually works. And so that's the takeaway from that. All right. Um, let's see. I think, all right. So I was going to stop with the stomach cancer, but I didn't realize it was rather short. And so I'm going to go ahead and talk about gastritis as well. Um, and so I think you guys may have had some of this already. I'm not sure, again, how much depth you went into it in your previous med surg courses. Um, but there can be some complications as it relates to a complex health. And so, with these conditions, especially the fact that these lesions can erode the mucosa all the way down to the blood vessels and cause a massive hemorrhaging, and that's pretty much the complex health part of that. Um, and so. Now, as we discuss gastritis, gastritis is an inflammation of the gastric mucosa, and it is one of the most common problems affecting the stomach. And gastritis, it may be acute, chronic, or diffuse, or localized, as you can see here. All right. As far as the pathophysiology, etiology, and pathophysiology, gastritis occurs as a result of a breakdown in the normal gastric mucosal barrier. And of course, we need that mucosal barrier because it protects those underlying structures in the stomach. And so this can cause a problem. This mucosal barrier normally protects the stomach tissue from the corrosive action of hydrochloric acid and also pepsin. All right. And of course, when that barrier is compromised, then those acids will then get to those structures below. So now, when the barrier is broken, also the hydrochloric acid and the pepsin, they can diffuse back into deeply into the mucosa. Now, this back diffusion results in tissue edema, all this inflammation from these enzymes and the acid. Um, there's a disruption rather of the capillary walls with loss of plasma in the gastric lumen and possible again hemorrhage. And so that the hemorrhage part is the complex health piece that want you all to really focus on. Very important. Because again, I know you all have probably had this before, but what we want you to focus on is the complex piece of it. All right. Now, as far as risk factors, take a look at table 41.19. Risk factors and causes of gastritis are listed in the table here. All right. So let's talk about some of the drug-related gastritis. Drugs contribute to the development of acute and chronic gastritis. You have drugs such as NSAIDs and also corticosteroids, and they inhibit the synthesis of prostaglandins that are protective to the gastric mucosa. So in essence, when this when these drugs reduces or inhibits the synthesis of the prostaglandins, then the gastric mucosa loses its protection. And so here again, we have to be cognizant of the fact that we may have to do patient teaching as far as NSAIDs are concerned. And of course, we may not be able to help but to administer the corticosteroids because the patient might need it, especially certain disease processes such as asthma or some autoimmune disorder and so forth. Now, because of the when the prostaglandins are not produced and the gastric mucosa is compromised or the integrity of it becomes compromised, now the mucosa becomes more susceptible to injury. All right. Some drugs such as digoxin and also Fosamax have direct irritating effects on the gastric mucosa as well. So when you're looking at your drugs and, especially that you're getting ready to administer, your patients may complain about, gastritis, some of these GI issues, symptoms, and if you will. And so you may need to go back and look at your drugs as a possible cause. Now, dietary indiscretions can also cause or contribute to acute gastritis. After an alcoholic drinking binge, acute damage to the gastric mucosa can range from localized injury of superficial epithelial cells all the way to destruction of the mucosa, which can result in mucosal congestion, edema, and then hemorrhage. Again, that complication that we are more concerned about. Now, prolonged damage induced by repeated alcohol use results in now chronic gastritis. Eating large quantities of spicy, irritating foods can also cause acute gastritis. All right, and so here is another health promotion and maintenance opportunity. Helicobacter pylori, or AKA H pylori. This is also a key cause of chronic gastritis. This particular infection. All right, and so this is actually the organism that causes acute gastritis in most people who are affected. Chronic gastritis may develop in some. There's also prolonged inflammation that leads to functional changes in the stomach and may cause a stomach cancer as well. That inflammation, it just changes the cells of the mucosa. And of course, these patients end up with cancer. Other risk factors. Now, although not as common as H. pylori, Other bacterial, viral, fungal infections are associated with chronic gastritis as well. Gastritis can occur from reflux of bile salts from the duodenum into the stomach because of maybe anatomical changes after surgical procedures, such as a gastro duodenostomy and also a gastro jejunostomy procedure. So normally when the bile is released from the gallbladder and it comes down the ducts and also into the duodenum, so that when fatty diets um, enter into the duodenum, then the bile can break down the fat for use. Well, some procedures may weaken the lower portion of the stomach, the pyloric sphincter, in other words, something like that. And of course, the bile can go back, or rather reflux into the stomach where it doesn't belong. And of course, when that bile, the bile salts, which can be very caustic when it makes contact with the gastric mucosa, and so that can irritate the gastric mucosa. Prolonged vomiting may cause reflux of bile salts as well. There's also intense emotional responses and also CNS, central nervous system lesions, may cause inflammation of the mucosal lining due to production of more hydrochloric acid, or hypersecretion of hydrochloric acid may occur as a result. So that intense emotional responses or CNS lesions. All right. All right, so let's take a look at some of the clinical manifestations of gastritis. The symptoms of acute gastritis include anorexia, nausea, vomiting, epigastric tenderness, and also feeling fullness. All right. Hemorrhage is often associated with alcohol use, and at times it might be the only symptom. And this is the one that we again really want to keep an eye on. Acute gastritis is self-limiting, lasting from a few hours to a few days. But when it is acute, um, complete healing of the mucosa is expected with the acute type, but not so much with the chronic type. Um, Now, the manifestations of the chronic gastritis are like those of the acute gastritis. Some patients are asymptomatic with the chronic type. However, when parietal cells are lost because of atrophy, remember the parietal cells are beneath the mucosa, and with this gastritis, sometimes it causes the tissue to atrophy, and of course you can't produce enough intrinsic factor, and of course intrinsic factor is essential for vitamin B, or rather, yeah, vitamin B12 absorption, um, or cobalamin. Um, uh, is another name for vitamin B12. And so the lack of vitamin B12 will result in pernicious anemia. And of course, you may want to just take a look at what those symptoms of anemia would look like. And of course, these patients, once you lose the intrinsic factor, they will likely need lifetime vitamin B12 injections. Take a look at chapter 30 if you want to maybe do a quick review of vitamin B12 deficiency anemia. That is important, especially with some of the symptoms like the tongue. I forget how it's described, but basically the tongue is beefy red, I believe, is what the literature talks about. Let's see. I can't believe I wasn't advancing my slides. I guess I just got too involved in what I was doing. Now, some of the diagnostic studies, acute gastritis is usually diagnosed based on the patient's symptoms and a history of drug and alcohol use. So during your nursing interview with the patient, these are things we want to ask these patients, especially during the admission process. Now, an endoscopic examination with biopsy is required to make a more definitive diagnosis. Um, there's also a breath, urine, serum, a stool, and gastric tissue biopsy tests that are done to assess for H. pylori infection, if that is the cause of the gastritis. Now, a CBC may show anemia from blood loss or lack of the intrinsic factor. So CBC is important. Stools are tested for occult blood. Serum tests for antibodies to parietal cells and intrinsic factor may be done as well. Remember, with antibodies, it's like an autoimmune condition, could be attacking the parietal cells. And of course, these patients will again suffer from pernicious anemia. And a tissue biopsy can also rule out gastric cancer, which that would be a concern. Um, that would be a concern in these cases as well. All right. Uh, I just want to look here to see if I don't know how much is here in these notes before I possibly sign off. It's not a whole lot. I mean, I could also go in and discuss the upper gastrointestinal bleeding, and it's rather late, but you know me. Um, so anyway, yeah, let's go forward. Might as well. Now, so let's go ahead and look at upper gastrointestinal bleed, and more specifically, the incidence and prevalence of this condition. And as you can see here in the U.S., 250,000 hospital admissions occur each year for upper GI bleeding. Um, about 60% of these are adults, and they are over the age of 25. Um, Now the mortality rate is it's a low 2.5, so not very high, which is good, of course, for these patients. All right. Um, so as far as the etiology or pathophysiology for upper GI bleed, now um, now most of the serious loss of blood from upper GI tract is characterized by sudden onset. It is insidious, occult bleeding, and it can be a major problem. But the severity of bleeding will depend on whether the origin is venous, or capillary, or arterial. And of course, we know that the difference between arterial and venous is going to be, if it's venous, it's slower. If it's arterial, um, we got a problem, because these patients will bleed much more faster. Um, all right. Now, take a look at table 41.20 for types of upper GI bleeding um, when you get an opportunity. All right. Now, bleeding from an arterial source is profuse. All right. And the blood is bright red. because it has not been in contact with gastric hydrochloric secretion. Once that hydrochloric acid gets a hold of the blood, then it won't be bright red at that point. Now, in contrast, the coffee ground vomitis means that the blood has been in the stomach for some time. All right. And so, time enough for the hydrochloric acid to work on it. Now, melena or black tarry stools occurs with slow bleeding from an upper GI source. So this blood actually goes through the digestive process and come out through the rectum. Now, the longer the passage of blood through the intestine, the darker the stool color because of the breakdown of the hemoglobin and the release of iron. So that's why the blood is much more darker as opposed to bright red blood that has not gone through that entire digestive process. All right. And table 41.21 lists some of the common causes of upper GI bleeding. So make sure you take a look at it. All right. Now, as far as the stomach and duodenal origins of the upper GI bleeding, peptic ulcers, um, they can occur due to the H pylori infection and also use of NSAIDs. And these are the most common causes of upper GI bleeding. And about 25% of people on chronic NSAIDs, such as ibuprofen, develop ulcer disease. Of these, 2 to 4% will bleed. So these are things we have to make sure our patients do understand. Many over-the-counter preparations also contain aspirin, and so again, these things that we have to make sure we're teaching patients about as well. All right. Now, we also have something called a stress-related mucosal disease, also called physiologic stress ulcers, which describes mucosal damage in the GI tract, ranging from a small single lesions to multiple gastric ulcers and major bleeding. Again, the biggest concern. Now, this stress-related mucosal disease most often occur in those patients who are critically ill, who may have sustained severe burns, trauma, as well as major surgery. All right. Patients with coagulopathy, liver disease, or organ failure, and those receiving renal replacement therapy are at highest risk for this type of condition as well. All right. Now, when we talk about the esophageal origin type, bleeding from the esophagus is likely due to chronic esophagitis, Mallory Weiss tear, or esophageal varices, especially what you would normally see, the latter one, the esophageal varices, what you see in your liver patients. Now, chronic esophagitis can be caused by GERD, also smoking, alcohol use, and the ingestion of drugs that irritate the mucosa. And the esophageal varices most often occur from cirrhosis of the liver, as I said, those with the liver conditions. All right. Now, these are some of the diagnostic tests that you should be aware of. The endoscopy is the primary tool for diagnosing the source of bleeding, be that esophageal varices, peptic ulcer disease, or gastritis of the upper GI bleeding. There's also an angiography is used when the endoscopy cannot be done or when bleeding persists after the endoscopic therapy. And this test can just help us to locate where the bleeding is coming from. Now, the angiography requires preparation and setup time, and it may not be appropriate for a high-risk, unstable patient. In this procedure, a catheter is inserted into the femoral artery, and it is advanced to the left gastric or superior mesentery artery until the site of bleeding is found. Now, laboratory studies will include a CBC, BUN, serum electrolytes, your clotting studies such as your prothrombin time, partial thromboplastin time or PTT, PTT, liver enzymes, ABGs, and a typing cross match for possible blood transfusions, which might be warranted if the bleeding is significant. Now, all vomitis, and stools are tested for gross and occult blood. Remember, the blood may not be visible, and so we want to use our occult device, or rather tool, to assist us in this effort. Now, we also assess the patient's BUN level. Think about it. Now, during a significant hemorrhage or bleeding, the GI tract bacteria breaks down proteins. And when it breaks down to proteins, it results in an increased BUN level. Remember, the byproducts of proteins is BUN, blood urea nitrogen. That's the nitrogen part in particular of proteins. And so anyway, it is the bacteria that breaks down the proteins, and this is why the BUN is levels are going to be increased. And so this is a lab test that needs to be done. I don't know why I didn't do that. All right. Now, there can also be an increase in the BUN level due to the fact that if someone is bleeding significantly, there's going to be hypoperfusion to the kidneys. Think about that pre-renal that we talked about. Remember, we talked about pre-renal, intrarenal, and post-renal. So in this case, if there's hypoperfusion, we're talking about a pre-renal issue here. And of course, your BUN can be elevated in renal disease as well. Pretty common tests that we run on these patients. And this is actually going to be the last slide before I sign off. Let's look at some of the interprofessional management here. This is when we get into that complex health kind of care, which is why you're in this class. And so with the interprofessional management, sometimes these patients, you have a massive upper GI hemorrhage. It's essentially loss of greater than 1,500 mLs of blood, or 25% of the intravascular blood volume, and that's pretty significant. And although 80 to 85% of patients with massive hemorrhage spontaneously stop bleeding, the cause will have to be identified and treated at once, as soon as possible, because it can occur again, and so we need to make sure it doesn't. All right. Now, the emergency assessment and management, a complete a history of events leading to the bleeding episode is going to be pretty much deferred until emergency care has been started. And so, we don't need to get into the history and physical at that point. We need to stop the bleeding, find the source, and take care of the patient. Now, to facilitate early intervention, it should be more of a focused assessment. We should focus our efforts or our assessment essentially on identifying signs and symptoms of shock, because if they're hemorrhaging, these patients will very well go into shock. So we're looking at symptoms such as tachycardia, a weak pulse, hypotension, cool extremities, prolonged capillary refill, and apprehension. All right. Um, Now, urine output is one of the best measures of vital organ perfusion, because if you have that hypoperfusion, the kidneys are not going to be perfused, and of course you will not, or the patients will not produce any urine. So an indwelling urinary catheter should be inserted, and the urine output should be measured hourly and accurately. So strict INOs, essentially. Hemodynamic monitoring provides an accurate and quick assessment of blood flow and also pressure within the cardiovascular system. And so remember, we went over that when we talked about the Swan-Ganz catheter and how it can show us the patient's fluid status, what their preload is, and the afterload, and if the SVR is too low, the patient is in or has hypotension, which can be severe depending on what those values are looking like. And so again, start bringing back those tools that we talked about in these conditions, because this is where they are more applicable and can provide us with um, lots of data that can be used to manage these patients. A central venous pressure line may be used for fluid volume status assessment. So think about the CVP or right atrial pressure. The CVP is central venous pressure, and this is when the proximal portion of that Swan-Ganz catheter can measure the volume. And remember that the value or range is between, I believe it's 2 and 6 or 2 and 8. If it's on the very low end, we're talking about dehydration or low volume. If it's on the high end, then we're talking about um, fluid volume access or fluid overload, if you will. Now, if a patient has a history of valvular heart disease, coronary artery disease, heart failure, a pulmonary artery catheter, again, may be needed, all right, so that we can better determine that fluid status. We also would have to give these patients a supplemental oxygen in order to increase their blood oxygen saturation, which, if they're bleeding, then it will likely be very low. Now, the patient is at risk for perforation and also peritonitis. Um, and so we have to do a thorough abdominal examination. We have to note the presence of an abdomen that is tense. It will be rigid, board-like abdomen. These are signs and symptoms that you will see on your boards, and so know them well on your regular tests that we give. And there may also be the presence or absence of bowel sounds. So again, really hone in on these. Actually, I'm going to color these red so that you will pay attention to those symptoms more. All right. Now, the type and amount of fluids infused are based on physical and laboratory findings. We generally use isotonic crystalloid solutions such as lactated ringers, um, whole blood, packed red blood cells, fresh frozen plasma may be used for volume replacement in massive hemorrhage. Um, and when upper GI bleeding is less profuse, infusion of an isotonic saline solution, such as normal saline, followed by packed red blood cells, can restore the hematocrit portion of the blood more quickly. And it does not create complications related to fluid volume overload either. So as far as endoscopic therapy, the first line management of upper GI bleeding is an endoscopy, because we have to locate the bleeding. Now, the endoscopy within the first 24 hours of bleeding is important for diagnosis and determining the need for surgical intervention and also providing treatment. So it is your first line, and I'm going to color that red as well. Um, All right. Now, the goal of endoscopic hemostasis is to coagulate or thrombose the bleeding vessel. So, in other words, we want to clot off the bleeding, cause a kind of a thrombose, again, so it can stop bleeding. And so, several techniques are used to do this. A, uh, a mechanical therapy with clips or bands may be used. There may be also thermal ablation, injection of epinephrine or alcohol, and this is what constricts the blood vessels, stopping bleeding. There's also clips and bands, or I should say, clips and bands are directly compress the bleeding uh, vessel, which is why we use those devices. Um, I don't know how that happened. Just a moment. Right. Now, thermal ablation cauterizes the tissue through applying heat to the bleeding site. So it basically kind of burns the site and stops the bleeding. Now, for varicose bleeding, other strategies include varicose ligation, injection of sclerotherapy, and also balloon tamponade. And you can find additional information on that in chapter 43. There's also surgical therapy. Surgical intervention is needed when bleeding continues, regardless of the therapy provided above, and when the site of the bleeding has not been identified. And so we have to go in there and do more or less an exploratory type of surgery, figure out where this is happening. Now, surgery may be done if the patient continues to bleed after rapid transfusion of up to 2,000 mLs of whole blood, or if the patient is still in shock after 24 hours. We need to figure out what's going on because their condition is just not going to improve if we do not. Now, the site of the hemorrhage determines the choice of surgery as well. And also keep in mind that the mortality rate increases considerably if the patient is elderly. So that's pretty much a given, right? Now, as far as drug therapy is concerned, during the acute phase of upper GI bleeding, drugs are used to decrease bleeding, to also decrease the hydrochloric acid secretion, and also neutralize the hydrochloric acid that is present. So, empiric PPI therapy with high dose of IV bolus, with a high dose of IV bolus, and then a subsequent infusion will be given in the form of an infusion, a continuous infusion, to decrease acid secretion. And this is often going to be done before the endoscopy procedure is done. And take a look at table 41, point 10 for additional information on that. Now, efforts are made to reduce acid secretion because the acidic environment can alter platelet function and interfere with clot stabilization. Um, so this may decrease the amount of bleeding and the need for an endoscopic therapy as well. All right. And now, and lastly, after an acute phase of bleeding, antacids may be given hourly, either orally or through NG tube. If the NG tube is in place, the stomach contents should be aspirated and tested periodically for the pH level. If the pH level is less than 5, intermittent suction may be used, or the frequency or dosage of the antacid or anti-secretory agent has to be increased. All right. I think that's about it. I'm going to go ahead and stop right there. So we've covered a few disease processes. We looked at gastritis, a gastric cancer, and then upper GI bleeding. And like I said, I want you to really focus on that massive hemorrhage, which relates better to why you're in this class. This is the focus of that complex part of this disease process. So make sure you keep that in mind as you listen to the voiceover. So I'm going to stop sharing here, and let me go ahead and stop this recording. And I do certainly thank you for listening to the voiceover. And again, hopefully, rather, it will help you understand the information better.